Okay.
Started.
Perfect. Is this working? Is this live?
You are live, Tim. Welcome. Thank you very much. We have delegates online waiting to hear from you.
Brilliant. Okay, so let's just get this all up and running. Okay. So it's good to be here talking to you guys, and let's just get my screen ready. So I wanted to talk today about spinal rehab, and actually we can cover any kind of rehab today. So if there's any questions that come out from today, put them in and we'll talk through an exercise program, how to make an exercise program. So I'm a osteopath and physio, amongst other things, but mostly osteopath, and I am the founder of Rehab My Patient. Rehab My Patient was developed because I was just so frustrated with the main exercise prescription software program out there that I just thought we have to do something different. So I built my first version in 2005, and my sister was the model, and it just didn't work. And then we rebuilt it again in 2010 or 11, and then it didn't work, and we rebuilt it again, and then again. So we're on our fourth or fifth version of the site, and through that period of time, I've built up the sort of a good knowledge of rehab, especially through the physio stuff. So today I'm going to talk about spinal rehab and things you can do with your patients to improve any aspect of their spinal pain. Now I'm going to try and share my screen. So let's just see if this works. Katie, you might need to help me with this.
Happy to, Tim, if you have any problems. We can see you and we can see your screen, Tim, your PowerPoint slide.
So you can see it now, right? You can see my screen.
Yep, we can.
And you can see me?
Yes, we can.
Perfect. Okay. So let's do this. Now let's just make this in presentation mode. Right, so what will we cover today? Well, we'll look at typical causes of lower back pain and neck pain. We'll just touch on that fairly briefly. We'll understand a little bit more about back function. We'll look at treatment versus rehab, which will be a big question on everyone's minds, I'm sure, is where does this fit in with our model? We'll look at some practical exercise rehab examples and program creation. So a little bit about my experience. I'm qualified BSO 2002, then MT in sports physio. I'm also a non-medical prescriber and an injection therapist, and I've done a lot of very, very complicated spinal treatment and rehab. So I work very, very closely with a wonderful spinal surgeon in Croydon, where I work. So obviously low back pain is very, very prevalent, and I think it's going to be interesting whether we get an increased prevalence following COVID. I don't know if anyone saw the Telegraph article on Monday, but the Chartered Society of Physiotherapy have predicted a tsunami of rehabilitation needs following COVID. And I don't know how big this is going to be, whether it's just going to be because people cannot get access to the current hospital services at the moment and the NHS care, and whether it's all going to pile up, or whether actually a lack of mobility, a lack of exercise is going to contribute to more pain. I think probably both are going to be factors, and I think we'll see a real increase in musculoskeletal pain after COVID, as for a number of reasons. I think the lack of exercise is the key one. In addition, I think that social distancing may be good for preventing the spread of viruses, but I think it's not so good for mental health. And when people have low mood, they also typically tend to get pain, and that often reflects with neck pain, back pain. It tends to go to the bit of the body that most seems to hurt. Now let's look at the NICE guidelines. So what are in the NICE guidelines these days? Well, self-management, of course, Group exercise classes, absolutely. Big push for self-management and group exercise. You know, there's a number of reasons for that, possibly because of the model in the UK at the moment is typically around self-management and group exercise classes. Psychological therapies with exercise is a big yes. Manual therapy with exercise is in. What's out? Support belts, orthotics, rocker soled shoes, acupuncture, electrotherapies, paracetamol, antidepressants, and spinal injections and disc replacements are not so popular. Now, that doesn't mean to say that that's a absolute rule, because there are plenty of people that do respond to certain things on this list, like acupuncture, for example. And there's cases where people respond very well to spinal injections. But I think what they're saying is these are guidelines, and if we try and follow the guidelines, then I think it's going to best benefit the majority of our patients.
Tim, sorry to interrupt. We are seeing your screen, but the slides don't seem to be changing. Would it be possible for you to see if maybe we can kickstart that again for the audience?
Yeah, sure. I'll just reopen it now. Okay.
Thank you. Sorry to interrupt.
That's right. Can you see it? Can you see it now, Katie?
Yes, I can see disc bulge, herniation.
Perfect. If I scroll to the next screen, can you see that?
Yes, I think it's moving now. Thank you very much, Tim.
No problem. So we've just looked at the nice guidelines. We didn't miss much. It's just text really on a page. So common things we typically see. Well, I guess the disc is one of the most common. Those dreaded disc bulges and disc prolapses, they can really be a nightmare to treat, and sometimes when treatment just doesn't work, actually rehab can be really useful. Exercises can be very useful, and advice can be so useful for these people as well. But these disc problems are a big problem. Why are they such a big problem? Well, it's multifactorial really, but my feeling is it's really due to a high prevalence of forward bending. So you can often see the straightening of the spine. That's a sign which you see in people that do a lot of forward bending, or people that have degenerative spines typically have straighter spines. Not always the case, of course, and people that load their backs too much. I think nutrition has a factor as well. So good nutrition often helps the structure of the disc, especially the fibers around the disc, and the ligament integrity of the posterior longitudinal ligament. Just loading, we just seem to be putting a lot of load through our back, probably through long hours of sitting at computers like what I'm doing right now, doing these webinars. Right, just a visual picture of a disc prolapse here. Then we've got our spondylolisthesis. So they tend to be instability, and spondylolisthesis is one of those things that actually does tend to be very rehab focused. Rehab is very good for it. It's much better than manual treatment. Manual treatment, I mean, the thing about manual treatment is very good for mobilizing and for stretching and lengthening and improving range of movement. But spondylolisthesis is one where really we often say to ourselves, well, do we want to focus more on stability and strengthening? And that is definitely one where we may need to step away a little bit from our manual therapy and work more on our rehab. A couple of examples of a grade 1 to 2 spondylolisthesis there, and a large grade 3 spondylolisthesis there. And post-operatively. Post-operatively is always a nightmare when they fixate the spine. The two-level fixation is not quite as bad as a 3-level fixation. It's very traumatic, and we can often be rehabilitating our patients for up to a year following spinal surgery like this. Everyone will be familiar with ankylosing spondylitis. So, you see this typical straightening of the spine, which is a very, degenerative appearance, and a narrowing of the disc space, so a dehydration of the discs, and sacroiliac joint osteoarthritis as well, which is not so common. Degenerative disc disease, very, very common. Responds very well to exercise therapy and manual therapy as well, and typically requires sort of a management approach more than a cure approach. And there's our degenerative disc disease, and you can see the degenerative signs here. So you see the narrowing of the discs, the darkening of the disc, as well as the water tends to dehydrate away from the disc. You can see the disc bulges, and the posterior longitudinal ligament coming down the back, the spinal cord in the middle. And muscle tears, well, they're very rare, so we don't tend to see many muscle tears in the spine. We sometimes sort of see some muscle tightening or spasm, but we don't really see muscle tears because the muscles are very much, the erector spinae are very much grouped together and are extremely strong. They're not really prime movers as well. They're much more designed for stability of the spine and posture. So we don't tend to see them really damaged or torn like you would with a bicep, for example. And of course, fracture is the one that we don't want to miss. Easy to miss, and can be a real problem. I see about 3 fractured spines walking in every year. Often they're osteoporotic. When I do training with my team, I always train them on how to spot fractures in the spine, because I have been in a position where I have missed a fracture, and I'm sure there's many people out there that have, and sometimes they're just not that apparent. Fractures, I mean, what do we look for with a fracture? Well, we see typical traits. Number one, we tend to see the patient tends to be a little bit older. Not always, but usually. They may be osteoporotic, but we didn't know it at the time. They tend to have a fracture slightly higher up at the top of the lumbar spine, not at the L5S1 or L45. So typically we often see osteoporotic fractures at the T11, T12, L1 area. So the junction, the thoracolumbar junction. When they come in, they may have had a fall. Usually they've had a fall. And that's a key sign. You know, when a patient comes in with a fall, that's when we sort of say, hang on a minute, do we need to just be a bit careful here? If they come in with a fall and they have pain around the thoracolumbar area, without a doubt, I will send them for further investigation, usually an MRI or maybe an X-ray. And I don't take any chances with it. And as I say, I pick up at least 3 people a year who walk in having had a fall or a spinal injury in that method. How do we examine it? Well, we usually do 3 things. We'll often palpate the vertebra, so we can palpate the spinous processes. Not particularly accurate, because obviously it's the vertebral body that tends to collapse, not the spinous process. There's no fracture to the spinous process, so you know you're at least 1.5 to 2 inches away from the vertebral body, which is actually dropped down because it's an anterior fracture, an anterior wedge fracture. We'll palpate, so we'll percuss, so we might just tap the vertebra, and we might do a compression through the shoulders just to see if it replicates pain. But these tests are notoriously unreliable. I've had plenty of people where we know they've got a fracture and the tests are negative. So one thing you might see is a localized kyphosis at the vertebral level. So you might see a forward bend, and that is another strong sign of vertebral fracture. There's a fantastic surgical treatment out there called Kyphoplasty, and this is one guy who does it, called Michael Kochber, who's one of the world's leading experts in kyphoplasty. Here's an example of a fracture on an MRI scan, and here's the kyphoplasty that's been. So what kyphoplasty is, they use a tube that a very thin. It's thinner than the width of my finger, and it goes into the vertebra and it inflates a balloon to create space. Then the balloon and tube is pulled out, and then another tube goes in and fills the space with cement, and that hardens within a couple of minutes. And the idea behind it is it stops further collapsing of the vertebra. So often you'll start with if it's an osteoporotic fracture and it's non-traumatic, you'll actually start with an end plate fracture first, which will then progress to a full spinal vertebral collapse. So the kyphoplasty does have a place, and some consultants do believe it actually restores some of the vertebral height as well. But these people always need rehab after kyphoplasty or after fracture. Coccydynia, so acute pain, inflammation at the base of the coccyx, common sitting problem, and can happen in pregnancy. And our acute back pains, these are usually our facet joint type pains, or could be acute disc problems. Good. So next, we probably want to look at the shape of the spine. So we look at the shapes and we say, well, what's happening with this spinal curves? You know, is there an exaggerated lordosis, or is there a flattening of the spine? And these presentations as well suit very well to rehabilitation. So with a hyperlordosis, you know, we'd look to do exercises that would flatten the lumbar spine. Now, I know there are techniques where we can posterior rotate the pelvis, which is a well-known osteopathic technique, where we lie our patients supine, we place the hand under the sacrum, and we physically posteriorly rotate the pelvis. But, you know, I don't really believe they have long-term results. I think really we've got to use corrective exercises to achieve these results. And more commonly, we will actually see people with flat lumbar spines, or a flat or a reduced lordosis in the lumbar spine. And that's when all our extension exercises, if the patient can tolerate them, are really, really useful. So here's an example of a hyperlordosis here, and you know, an increased kyphosis here through the thoracic spine. It's one of my patients a few years ago who had a very big kyphosis in his thoracic spine, and struggled with very chronic pain. And of course, scoliosis, which everyone will be familiar with, and the surgical options after scoliosis. Good. So now I'll get on to showing you some exercise rehab, and I'll show you how I exercise rehab. So there's a few sort of things that you can do. Now, there's lots of different theories around spinal rehabilitation. Some of the theories include core stability. Now, core stability is a very questioned concept, and there's still a lot of research that backs up core stability. I was meant to be lecturing in Monaco for the International Olympic Committee in March on core stability and the new theories behind core stability. So I did a lot of research looking it up. There's still a lot of evidence that backs up core stability, and there's also a lot of evidence that core stability can help reduce back pain and back pain sufferers. But what we can't find is a lot of evidence that actually backs up the prevention of back pain, and that's the key thing. So what we don't know is, doing a core stability exercise, does it prevent back pain? Well, I think as clinicians we probably would say that it does, but there's not much research that actually supports it. However, I don't like the term core stability. I don't focus especially independently on core stability. I think that I use it as, I like to think of it as core strengthening. So I think that the core is an area we strengthen as we would strengthen the back, as we would strengthen the shoulder, or as we would strengthen the neck. I don't just look at core. And I think that, I mean, a good example is there's no point having a strong core if you've got an unstable ankle. You know, so we almost want to look at the whole chain and work out what needs to be stabilized and strengthened, not just the core. So I don't focus much on core stability. So there's lots of different ideas on spinal rehab, whether it's flexibility, whether it's strengthening exercise, whether it's primal patterns, whether it's isometric exercise, whether it's eccentric exercises, and there's all these different theories on it. And do you know what? Actually, there's no general consensus. There's no right or wrong. It's really much about as much about what you want to do as a therapist and your approach and what works for your patient. I would say any method can work as long as you back it up with your clinical experience, research where there is research possible, and listening as well, and adapting to the needs of your patients. So it's not a one size fits all. It's using different methods and methodologies to work with different patients and treating the patient as a patient, not as a condition. Some patients are going to be hypermobile. Some patients are going to be weak. Some patients are going to be stiff. Some patients are going to have good core, and some are not going to have good core. And so I think this is where we adapt our treatment rehabilitation to the needs based on the examination of our patients. I always feel if you want to rehabilitate, the best way is to go bring it back to basics. You know, is the muscle short? Well, let's lengthen it. Is the muscle weak? Let's strengthen it. Is the muscle is the joint unstable? Let's stabilize it. So if we look at those principles, that can work very, very well. So my method, first of all, I like to reduce inflammation and pain. Then I like to improve range of movement. Then I stabilize, then I strengthen, and then I look at functional return to play. So let's look at a couple of examples. Let's just see if I can bring up my software here. So I'm not sure whether you'll be able to see my screen now. I don't think you can. Great, hopefully you can see my screen. So I've just logged into Rehab My Patient, and this is not a sales pitch for Rehab My Patient. This is a demo of what I use, which is my software to prescribe exercises, and it works very, very well. There's other ways to prescribe exercises. This is just makes life a bit simpler.
Hi Tim, sorry, it's Katie again. Just saying I don't think we've got your screen up at the moment. That's your slides.
Can you see the page now?
We can see your screen with slides.
Okay, I'm just going to stop and share it.
Yeah, great, thank you.
Sorry, I've just shut that down. Try that now. It's, oh, I see. So let's just try that one. Does that work there?
Yep, I think that's good. Thank you very much.
Good. I mean, we usually have My Patient, a lot of osteopaths use it, and it's I designed it because I just wanted something fast and easy. When I prescribe exercise plans, I tend to keep them really simple. I don't like the really complicated stuff. If my patients are particularly athletic or very into a particular discipline like Pilates, then I can do more complicated programs, but I love the simple stuff. So I'm just going to show you how I do some exercises based on simple rehab principles. So let's start with our typical acute lower back pain. Okay, we all see it. Patient comes in, they're probably listing forwards, they're probably looking very stiff and very uncomfortable, and we want to improve range of movement in their back, or we want to, what's our first step? Actually, probably the first thing we want to do is to reduce their pain. Let's reduce their pain and possibly reduce their inflammation. Now, there's lots of theories about whether you should or shouldn't reduce inflammation. Inflammation, yes, it's a natural healing response of the body. So we want some inflammation, but the general feeling is there's possibly sometimes the body creates too much inflammation, and why there's a strong pain response. So in some cases, we want to reduce inflammation as well. As a practitioner, you need to make your own judgment call on whether this ideology or ideas really match with you and your patient. For me, if I think there's been an overreaction of inflammation, I want to reduce the inflammation. So for the short period of time, I might recommend things that reduce inflammation, like improving range of movement or using ice. And if they went to their GP, they'd probably be prescribed an anti-inflammatory like naproxen. and possibly coupled with omeprazole to reduce the hydrochloric acid production in the stomach. And so that's another way to reduce inflammation. And there's no doubt that that can help our patients in the short term. So our patient comes in, acute back pain. I'm just going to search for some exercise. First thing I tend to do is I typically tend to reduce the amount of forward bending they do. Now, I know that the evidence on that is limited, and I'm not saying that this is applicable for everybody, but I like to reduce forward bending because when you load the back, it's often with bending, and the L45, L5S1 is a real hinge point for flexion. So as you flex from that part of the spine, it puts a lot of load through the back, and we tend to see acute back pains that often occur from trivial flexion. So patients will come and they'll say, well, I moved the fridge a week ago, but yesterday I bent forwards to pick up a piece of paper from a desk and my back went. That's really, really common. So it's often that flexion process that tends to cause the acute back pain, especially when it's not when you're not bracing or you're not supporting the spine through holding your breath or through tensing or bracing your abdomen, such as when you lift something heavy. Then I like the lumbar rotation exercise. So I like to drop the knees to each side, lie flat on the back. It's just a nice, easy exercise. It's great to reduce inflammation and pain, helping fluid mechanics. I love the chair rotation exercise, and I love the side flexion exercise. I favorited these exercises, so they just come at the top. So I can really quickly just prescribe the ones I want because of the number of acute back pains that tend to pop in. And I might recommend some ice to the back as well. So let's just apply some ice. I might save that as well. And let's give them an advice sheet. So let's give them an advice sheet on facet joint syndrome. Good, add that there. I'll show you the advice sheet. Now, why do we give them an advice sheet? Because by giving them an advice sheet, it tends to give more information to the patient. I think if you can explain to your patients what's wrong, and you can give them some information and some advice and give them a sheet to go away and read, I think it can be really powerful. So it really enhances our treatment. I'm going to select my patient. So I would just select a test patient, and I'll call my back pain acute lower back pain. Press continue. Put in your sets and reps. So I think probably now a big question I often get asked is how many times should you do an exercise repetition? So there's no set answer. Now there's always a lot of people that do the sort of typical 10 by 2s, 10 by 3s. Now I'm not saying that's right, but one thing is that when you keep it simple, patients understand it. Now, with a mobility exercise, it's quite straightforward. I mean, you typically just do the mobility exercise several times, and you might do that several times a day. Typically 10 or 15 or 20 times to each side is typical, because it's a mobility exercise. We want to improve the mobility. We don't want to create too much pain, so we might be cautious how much we prescribe the exercise in the first week. So we might keep it quite gentle, and we might do that anywhere between 1 and 5 times a day. Now, there's no rules. You might do it 10 times a day. You might be doing an Achilles rehab eccentric exercise based on the Alfredson technique example paper that says you should do it 75 times a day. So it doesn't really matter. You base it on your own clinical judgment. But if we do this repetition 15 times twice a day, we'll do this one 10 times twice a day, and let's do this one 10 times twice a day. We'll use the ice for 10 minutes twice a day. Now, again, with ice, when I did my master's at Bath University, I actually had to present a mini project on ice and heat, and whether ice reduces inflammation or not. And I looked for all the papers, and it's amazing that on research papers that they don't really go into there's no general consensus over how long you should actually use an ice bag for. So I just tell all my patients use it for 10 minutes, and that works for my patients. It might not work for yours, and you can decide what works for you and your patients, but 10 minutes a couple of times a day is easy, it's achievable, it's not too hard that it puts people off, but it's easy to do. Great. So I'm just going to save that, and I'm going to well, normally I'd email it, but I haven't actually got an email address onto this patient. So let's just add his email address. So let's just put in, save that. So we would email the program to the patient and it's done. I'm actually going to save that as a template. So I'm going to export that to template. And now I've got the template in there. So whenever any of my acute back pain patients come in, I can just really quickly assign it to a patient. Let's send it to Stephen Bruce, because I'm sure he's had a bit of back pain every now and again. That's done. And I've just emailed that to him. Good. So I'm not sure if anyone was watching my last webinar with the APM, but the APM have been putting on some very good webinars, free webinars at lunchtime, much like the IO. And I was just doing a talk on there as well. Good. So I made my exercise plan, dead easy. And so that's my acute rehab phase 1. I'm just going to see if I've got any questions. Katie has.
We did have one question that's asked if you could repeat your 5-step rehab protocol, Tim, that you mentioned.
Yeah, sure. So so this is my method, and I'm not saying this is the right method, but it works really, really well for me. Step 1, let's reduce inflammation. So typically we might use ice, we might use gentle mobility exercises, we might try and avoid aggravating the area. So on my rehab program here, step 1, let's avoid upsetting the back, let's minimize forward bending. This is my approach. Let's do some gentle mobility stuff and let's use some ice. So that will reduce inflammation and pain. Step 2 is let's improve range of movement. So here's my range of movement exercises. Now, these are week 1 or 2, these are week 1 exercises, but then after week 1, I'll actually move on to week 2 and let's do some slightly stronger exercises. So let's do some side flexion with the arm overhead, or let's do some we may even do a Mackenzie slide if they've got a disc problem, for example. Okay. So phase 2, let's improve range of movement. Okay, let's kill the ice because we're not going to use ice anymore because it's probably not so acute. Here's my, and we can let our patients start bending gently if they can tolerate it. Acute lower back pain week 2. And there's my program, save, and I better not keep emailing Stephen Bruce, but you'd email it. Okay, so step 3 is let's stabilize. So we've improved range of movement. Let's build stability to the spine. So stability often involves non-big movements, if you like. So they're not sort of contractile movements. And they tend to focus more on joint stability. Whereas when we talk about strengthening, we're sort of probably focusing a little bit more on the muscles and the prime movers. So with stability, we let's look at our stability options. So let's just go to lumbar spine and let's click stability. Let's see what we've got. So physiotherapists absolutely love using blood pressure cuffs to contract the transversus abdominis. Here's one such exercise, not particularly practical for your patients at home, but you can do it in the clinic. And exercises like a one-arm Superman are great. You know, this is a good stability exercise. We just hold the position and it will improve stability to the, in this case, lumbar spine, lumbar rectus spinae, thoracic rectus spinae, cervical rectus spinae, tricep, a little bit latissimus dorsi, and the and a little bit around the rotator cuff like the teres. We might do a 4-point. Now, most exercise on 4 points are very good. So the horse stances are excellent. This is a brilliant stability exercise program. It's just a gentle weight shift on all 4s. So it encourages the contraction of the deep abdominal muscles. It activates the proprioceptive and smaller muscles around the lumbar spine and helps us to build that stability up around the joints. And now if we want to go into, once we've built up the stability of our spine, we might want to then move on to a strengthening program. Now, strengthening often involves a little bit more movement, and we'll often use the, we'll just go to the strengthening category, and we might use repetitions rather than holds. So rather than holding a position for say 30 seconds, we might now go on to lifting an arm and up and down, okay, to activate the muscles a little bit more. And the most prescribed exercise, so on Rehab My Patient, we've prescribed exercise to over 750,000 patients. And this one exercise here, Supine Bridge, is the most prescribed exercise across the whole database. So it's a very common mobility and stability and strengthening exercise. It's very easy to do. Patients understand it. It's very easy to progress. So with the Supine Bridge, you can start with just the floor and a mat, a gentle contraction of the deep abdominal muscles, and you slowly lift the spine away from the floor. If you're a Pilates instructor, you might use the cues like peeling your spine away, and you can use the arms to help you lift up. Okay, and we can progress from a basic supine bridge to a arms across your shoulders. Now, what this does is it reduces the stability. So you've got less points of contact with the ground, which means you're having to use your core more and your back to stabilize you more. And by placing your arms across your shoulders actually makes the exercise harder because you're not relying on your arms to push you up. So you're really relying on that core and lumbar strength. From there, you might progress onto a single leg bridge. It's much harder. Again, you've got less stability. So you've only got one foot planted on the ground, and it's a strengthening exercise as well. And you come up and down, or you can hold it for a stability exercise. Because you're less stable, you're having again to work the core much harder. From a single leg bridge, you can then cross your arms over your shoulders. So that means you've got even less stability. That now becomes a much tougher exercise. The less stability you've got, the more you have to rely on your own body stability to hold the position. You can do Swiss ball bridges. So again, a ball is less stable than you planting your feet or using a chair, and so you're relying on the core to activate. And then a core one leg, and moving on to a core with no arms. And there's all sorts of variations as well. So that's the strengthening program. So let's first of all add some stability and strengthening in. So we'll add two progressions here. We'll do a stabilization with mobility, lumbar control, and let's do a Superman on a ball, which I love. There's my stabilization program. Let's just prescribe that to gym patient, and this will be lumbar rehab weeks 3 to 4. Press continue, put in my sets and reps, and save and email. Okay, good. Now we'll then go on to the strengthening. So let's add our bridges. We'll start with a basic bridge and we'll progress to a medium bridge. And let's do another ball exercise. Actually, let's go on to a more complicated horse stance as well. Great, so there's my weeks 5 to 6. Putting sets and reps and done, email, good. Now the last phase of rehab tends to be the functional return to play. Now with functional, we tend to do more multi-joint exercises. The idea behind functional is basically we need patients to actually get back to normal living. So normal life involves squatting, it involves bending, it involves lunging, it involves reaching, it involves stepping, it involves twisting. So functional stuff, it might be we want to get our patients swimming, it might be we want to get them running. So that a functional exercise might involve something like a hop. It might involve a wood chop. It might involve a twist or a rotation. So these are all kind of good rotation and functional exercises. It might involve a squat. Now we all got to sit in a car and we all have to sit on a toilet. And if people can't tolerate to do that easily, they're going to be round in their back and not maintaining good posture when they sit. So doing these exercises, it might start off with a gentle wall squat or a ball squat. You know, it might start off with something like this, progressing onto a half squat, then progressing onto a full squat. So you might do a single leg squat or a full single leg squat. You know, so you know you can really progress it more functionally, and this is really good for movement and functional return to play, whether it's back on a field or whether it's hiking up a mountain or whether it's going swimming or whether it's any particular sport. These are the sort of exercises that we do, which are more multi-joint exercises. So that's how I would do a rehab program, looking at the 5 stages of rehab for an acute back pain. And I'd throw the questions open to anyone watching. Is there any conditions that you want me to demonstrate how I would rehabilitate, and what exercises you'd like me to go through? So let's see if there's any questions coming up. I'm not sure exactly how to see all the questions.
Would you like me to give you some questions that have come through, Tim?
Yeah, let's do that. That'd be great, because my control panel is really small.
Right, we've had a number of questions around the program specifically, but I think what we'll do is we'll go straight to the conditions that are coming through from some of the delegates.
Yeah.
So spondylolisthesis.
Spondylolisthesis. Okay.
Recommendations there.
Okay, so spondylolisthesis is one of those very complicated things to treat manually. You know, first of all, they hate extension. They don't like being lying on their front on a treatment table often, and they don't really suit manual therapy very well. They can be a bit aggravated if we do a lot of massage on them. Manual therapy can often provide symptomatic relief to a spondylolisthesis, but I don't think often provides a great long-term benefit for spondylolisthesis. I think, and I'm sure there's people out there that do have very good successes with manual therapy and spondylolisthesis. That's fine, but I think using an integrated rehabilitation and exercise approach can be way more beneficial. So first of all, let's find our spondylolisthesis advice sheet. So first thing I want to do is really really guide people on what is a spondylolisthesis and how can we help our patient. I mean, so let's give them the spondylolisthesis advice sheet, okay? And then they can understand a lot more about their condition. So we'll add that. Now, following our principles, so first of all, we want to probably reduce pain. That's why they're seeing us. They're sort of in pain, so we could prescribe gentle mobility exercises. I mean gentle, like we're not stretching, we're just mobilizing. So again, a supine rotation should be very, very safe, like a lumbar rotation, and we might prescribe some ice or heat to help with the pain relief. Okay. Now, following on from that, we actually go through that phase very quickly. So we move very, very swiftly onto stability exercises. With a spondylolisthesis, we want to stabilize as much as possible, and we want to do it really, really slowly. There's a lot of benefit with things like Pilates in this category, or even antenatal Pilates, because these can occur in pregnant ladies as well. But let's go to, for example, our Pilates section. So some really good stability exercises like a tabletop or a knee folds or a one leg stretch or a double knee folds, you know, are really excellent for doing some stability work. Spines in neutral or flat, and so it's not in a hyperlordosis. You know, generally we want to avoid the hyperlordosis, so we're not going to do any extension-based strengthening. We probably want to strengthen in neutral, or we'd first want to see if they can tolerate it. So anything where we might just stabilize in neutral is definitely best. So we might do some abdominal hollowing or some contractions of deep abdominal muscles to start with. Okay, teaching people how to use those deep abdominal muscles, and the blood pressure cuff again works very well, something that we tend to do as well. So they don't need to use a blood pressure cuff, but they can just gently contract against a towel, flatten the back into a towel, and then from there you can move one leg. So you're not hyper arching the back, you're just learning how to use the limbs from a flattened lumbar spine or a contracted deep abdominal muscles. So I would really focus very much on stability exercises in neutral. I think this sort of thing is okay as well if there's not too much extension, but you've got to just be careful not to overextend. And it's all about holding a position. So it's a lot about stability. So we want to hold the positions for a prolonged period of time. And then, of course, from stability, we can go on to strengthening and then on to functional exercises. So that's where your lunges, your squats, and your bigger movements come in. Okay, Katie, any other questions?
Thank you. Yes, thanks very much, Tim. That was very informative. We have got quite a few coming through. I'm not sure if we'll get through to all of them, but certainly we've had 2 requests in terms of ankylosing spondylitis or inflammatory arthritic conditions. What
Let's do AS.
Beyond that?
Yeah, let's do AS. So it's quite common, isn't it, that we see, well, not common, but we certainly see patients with AS come in. Again, first of all, I want to give some advice. I really want to give them the advice of ankylosing spondylitis and go through ankylosing spondylitis and what it is and educate my patients. So I would always spend a little bit of time just talking them through it and explaining why they might have got it, so they understand that it's nothing that they've done wrong. It's just, it's very much a marker, a genetic marker. So I'd give them advice. And with ankylosing spondylitis, so we know it's inflammatory. So again, we really want to think, how can we reduce inflammation? And one of the best ways to reduce inflammation is mobilize. So let's get them moving, right? That could be something as simple as walking, okay? So we could just give them a walking exercise. And that may be challenging for some people. It might be walking sideways or walking backwards, or it could be some specific mobility exercises. I mean, a chair side flexion exercise is always a good one. Just something simple they can do in their chair just to mobilize the spine. Now, once we start mobilizing, we also want to try and focus a little bit more, if they can tolerate it, on gently encouraging some extension into the spine. Now, I'm not saying that we may get these patients straight. It may even just be a case of preventing their flexion deformities from getting any worse. But I do believe that if we can reduce inflammation and we can maintain mobility, we can prevent the severe onset to some degree. Now, there may be a natural evolution and deterioration of their symptoms until the point where it burns out. But I believe that if you can maintain mobility and reduce inflammation, you can reduce that process a little bit, or certainly help stop it from going too far. So we want to improve range of movement. So let's do any kind of mobility exercise where they may side bend, they may rotate. I love the chair rotation. It's a brilliant way to mobilize the thoracic spine. You don't involve any flexion, so we want to avoid flexion. So we're not going to do crunches or forward bends or forward reaches. We really want more to do, let's focus on rotation or extension or side flexion. So we can do a more advanced rotation exercise, or another one is here. There's lots of different rotation exercises. The figure of 8 stuff is excellent for pelvic mobility, especially the sacroiliac joints. So as we know, the sacroiliac joints can get quite degenerate from the AS. So this is good for them. And if this is it's a very advanced exercise, a Russian supine twist, but it's just an example of they wouldn't probably do that, but that's a much younger person's, if they're in their early 20s and still quite fit with it, and early stage. Any kind of rotation is really good. So we really want to focus on improving range of movement, stretching, and we focus less on stability because they usually get quite rigid. We're much more focusing on let's improve range of movement and reduce inflammation. Okay, Katie, back to you.
Right, thank you very much, Tim. So a couple of variations around sort of neck conditions. So we've got sort of cervical facet lock, stiff neck for headaches, forward head posture. Obviously all slightly different, but maybe we could talk through one of those, Tim?
Yeah, absolutely. Can you still hear me?
Yes, I
Still
can, yeah.
Yeah, brilliant. Sorry about that. Yeah, so what are we talking about? Neck, yeah. Good.
Yeah.
So now with necks, they love movement. And that's why they respond so well to osteopathy, don't they? They're a really mobile area, and pretty much anything in the neck tends to respond pretty well to manual therapy, I find. You know, we can stretch it, we can stretch the muscles, we can mobilize the joints, we can manipulate, we can do so many things to the neck. And so with rehab, again, you see, I follow similar principles. Let's first of all get the pain under control. Let's give advice and guidance. And also, I think it's really important with neck that we look at the ergonomics. So we might give them advice on ergonomics. And let's look at their posture. Let's look at their seating position. Let's see if their seating position is good, and whether they've got the correct setup. And also with the neck, you know, we want to improve range of movement. Let's get the neck back to full range. Now, typically full range would be being able to look sort of 70 to 90 degrees in rotation, yeah, or 15 degrees of side flexion. So we'd look and see how much rotation they've got, and then let's improve their rotation. Well, best ways to improve rotation is just to rotate. Let's keep it simple. So let's just go to neck rotation, and let's give them a neck rotation exercise. And if you want to give them a stronger neck rotation exercise and give them a rotation, get them to gently push their neck into rotation. Or a neck rotation with a pec stretch. You know, that's just good for opening up the shoulder a little bit and improving posture. Now, a lot of neck problems improve with posture. So we know a lot of people have forward head posture. Excuse me a second, getting a little bit of hay fever. We know a lot of people have problems with posture. So you have forward head positions, necks come up like so, rounded upper backs. A lot of laptop users in this position, a lot of phone users have flexed necks because they flex forwards to look at their phone or their iPad. And all of these two scenarios bring the head forwards. We know the head weighs 8% of body weight, so you're carrying, you know, 7 or 8 kilos of weight on the shoulders, and we know the neck muscles are not really happy supporting a heavy weight, a heavy head like this, right? So these neck muscles are really small muscles. They're not designed to be load bearing. They're designed to stabilize and to support the neck, not to take the full weight of the head with gravity. As soon as you bring the head forwards, you've got all that extra gravity on the neck muscles. So posture is so important. And anything where you extend the spine, I mean, like something like a dart or a cobra, is such a good posture exercise because you can retract the scapulae, so you can strengthen the rhomboids and the scapular muscles. You can bring the arms up. Oh, that's not actually going to work because I'm on screen share. You can extend the neck, so you can strengthen the neck into extension, and you can improve the strength of the thoracic rectus minor. So these are great posture exercises. I think improving posture is key for neck. So I give a lot of posture stuff. And I also like stability exercises, and we also have a very cool section. So Whiplash is another really interesting one. And there's an amazing guy, and if you're interested, I'll try and get him on a webinar called Chris Worsfold. Now, Chris is the Whiplash guru. He's a physio. He advises government on Whiplash, and he's created all these sensory motor and ocular motor exercises. And it might just be something like this. So what you'd do is you'd keep your neck straight as you move the arm, and you'd so it's hard to talk and do at the same time. So I'm going to look here, and I'm going to keep neck straight as I follow the arm to each side. to build up proprioception. So you do the pursuit exercises, and then you move on to an exercise where you rotate the neck and you keep your eye on your thumb. These are great exercises. And then you've got all the functional exercises as well. So when you want to come on to late stage, things like the commute. So the commute is you would walk across as if you're walking across a road and you were twisting to miss someone. So it builds in this functional rehabilitation idea on the neck. You know, another one is the forward reach. Well, it is a forward reach as you go to greet someone, and you do the exercise, or an avoid exercise where you imagine someone sort of chucking a ball at you, and you just avoid it. So it's a kind of cool like neck rehab exercise. Or the smooth pursuits again, where you walk and you keep looking at an object on the floor. These are all great functional exercises. Smell the coffee is another one where you just protract forwards if you want a protraction exercise. And of course all the laser exercises and eye exercises as well. Back to you, Katie.
Great, thanks very much, Tim. One question that's come in, which I think is worthy, just specifically on the neck, in terms of exercises for those with some level of nerve entrapment. Have you got any suggestions there?
Yeah, so let's look at nerve entrapment. I think in most cases, the nerves that get trapped in the neck, you know, we tend to find are disc problems. So we have to say to ourselves, well, why has the disc problem happened? Well, you know, there's different theories, but you know, my theory is really very much that we spend a lot of our times with our necks held forwards, so the disc tends to be under a lot of pressure. So I would encourage stability to the neck, mobility, and I would encourage good posture, and I would encourage advice. So with all my disc problems, first of all, I reduce forward neck bending. So I tell them to chuck their laptops. I've got my spare laptop here, chuck them away. Get yourself a proper screen and a setup and an office desk. And I know we all say it, but I mean, I really drill it into my patients. I really tell them, you know, you really need to do this. Okay. And I hit it on so many, I hit patients at so many different levels. You know, I'm on at their workstations, I'm on at their stress levels, I'm on at their things that are making them upset, I'm on at their exercises, I'm on at their soft tissue treatments. So with disc problems, first of all, let's stop aggravating the thing that's causing you a problem, right? Chances are you're creating your problem and you need to stop the aggravating factors. Yeah. If you stop them, then you're probably going to improve just by nothing else. Whether my manual therapy or not works, you'll probably improve. Then let's improve range of movement. So let's get the neck mobile. With a disc problem, often they'll be restricted in one position. They might be restricted to turning over the left shoulder. They might not like flexion. That might bring on symptoms into their arm. We find with disc problems, I mean, typically, you know, I'd say majority of people don't like flexion. And then there's a small number of people that don't like extension. They tend to bring on the symptoms. So we find out what they don't like and we avoid those movements with a disc. So if they don't like extension because it brings on symptoms, we don't extend, not till they can do it. If they don't like flexion, we don't do any exercise in flexion. We might instead do an exercise in rotation or in side flexion or stability exercise if they tolerate it. So we work out what the disc doesn't like and we go to a position of comfort with the disc. In fact, we do the same thing when we do our manual treatments. If we know they don't like flexion, we'll probably do a mobilization or manipulation into extension. And that works very, very well. So it's finding what the disc does and doesn't like, because the disc, you'll see the disc will bulge, you see. So you'll get the symptoms going down the arm quite easily from doing different movements.
Great, thanks very much, Tim. We're sort of running out of time. We've got some more questions I don't think we're going to have to cover in terms of conditions. There has been some interest in your Whiplash guy. So I think it would be good for us to possibly look at speaking to, I think you said it was Chris Worth?
Yeah, actually, I've actually asked him to come and do a webinar for me. And I'm sure he'll do one for you as well. So I'll let the guys know. But so he designed all the exercises for the site. And I spoke to him about a week ago, and he said he would do a webinar. So I can let you guys know, and we can do one together.
Excellent. So we'll let all the delegates know about the whiplash. One final question for just to which I thought was quite interesting in terms of do you create your exercise plans during your consultation whilst the patient is in front of you, or do you tend to do them at a later point?
I always 100% of the time do my exercise programs with the patient there. Number of reasons. Number one, I don't want to take the stuff home with me. I think it's nice when it stays in the clinic, although you can use this anywhere in the world. I have done exercise programs in an airport where, you know, patient texts and goes, can I have an exercise program because you're going away on holiday? Yep, bosh, get the app out, send it off. And I like to do it in the clinic because it just helps me finish that patient. They're done. I don't have to worry about going home and remembering to do it. It takes 2 minutes. It takes less than that. It takes 1 minute to do an exercise program. If we've got a half an hour session, you can do 5 to 10 minute chat and examination. You can do 15 minutes of treatment and 2 minutes of exercise prescription.
Very much, Tim. We had some other questions from delegates that were not so much spine and neck related, but maybe we might invite you again, maybe to do some shoulders potentially, or some other aspects, Tim. But otherwise, thank you very much. I will provide any other questions that delegates have that Tim about the software directly to Tim. So I'm sure, Tim, you can pick up directly with the delegates about that. And I don't know if you've got any last words, Tim.
Can you see me okay? I've just stopped screen sharing.
Yeah, we can see you. I certainly can anyway.
Good. No, but I'm really happy to come and do another talk at the IO conference last year. I did a knee rehab talk, and then the year before that I did was it? Actually, I think it was Clive. I think Clive Lathey did shoulders the year before that. And Clive actually is a brilliant guy for shoulders if you need shoulder rehab advice. But I'm happy to come on and do. In fact, you know what would be quite good to get me and Clive together doing a shoulder. I have no idea. I mean, if he'll accept, but
committing Clive before the event, great.
Yeah, no, I think we'll just agree now. We'll just say yes, we'll do it, and we'll work out the rest later.
Excellent. Well, thanks very much again, Tim. Thanks to all the delegates. A video of the webinar is going to be available, so if there's anything that you've missed, you can review. This does count for CPD, as you all know, and thanks very much again. Thank you very much, Tim.
Take care.
Bye.